HealthInfoNet is a public-private partnership in the state of Maine. It was founded in 2006 as a not-for-profit corporation. It has a community board of 19 that include both government-appointed positions as well as representatives from the 5 stakeholders. That would be providers, consumers, business, insurance, and government. It is focused today on dealing with the inefficiencies and patient risk factors that have handoff between points of service, and over the past 2 years has worked toward delivering a demonstration project. The objective of the demonstration phase really is 4 things. 1, we obviously want to prove the technology, the ability to reliably identify a person across points of service, to associate clinical content with that person, and then probably most importantly, present that content in the context of workflow so it's meaningful to the provider, so that there's an opportunity to use it to make a difference in clinical decision making. So that's really the objective. The demonstration phase is really quite significant in that it includes 6 provider organizations and Maine CDC. Those 6 provider organizations in Maine represent 50% of the inpatient discharges, 52% of the emergency room visits, and just a little over 40% of all ambulatory activity in the state. So, it's being called a demonstration phase. It's quite frankly a little larger than one would expect for a demonstration phase. We're very focused on something called parameter-based launch. You can think of that as contextual management. If you're in your EMR and you want to look at what's in the state exchange, you don't want to have to search that patient. So we've provided mechanisms on the various EMRs that are involved to be able to call the exchange, go through a security process, and be in the patient, not have to search. We expect that over the next year we will demonstrate some pretty significant areas of impact. Not surprisingly, most of the organizations have focused on starting in their emergency rooms if they're hospitals. The one ambulatory care provider, in this case an organization called Martin's Point, is obviously focusing on office practice, and that's very important to us because we want to understand workflows in the office practice and how to optimize use. But the 4 large hospital delivery systems in Maine, plus Franklin Memorial, constitute 15 hospitals that are associated with this demonstration phase. And they're all starting in the logical places. The emergency room obviously is a good point of attack. Many of them are also incorporating their hospitalists. Then the range goes very, very wide. One of them is incorporating their home health agency to see how that impacts home health management. Another one is incorporating their cancer program. Another one's incorporating their trauma program. So we've basically encouraged all these organizations to choose a path and then build to make the workflows within those clinical areas as effective as they can be. We're going to take a look at the impact on reordering or ordering of tests, particularly laboratory and diagnostic tests. One of the academic theories is that there is as much as 20% repeat testing as a result of an individual showing up in an emergency room where a test has already been done on that person recently in another environment. And so we're going to be testing that out to see whether we can in fact validate. Maine is blessed with a very unique structure. It has an all-payer claims database that allows us the opportunity to look at usage behaviors in prior years. And so we'll use that very heavily as the analytical backdrop, both for the prior year and obviously in terms of utilization during the current year. A stated objective is to demonstrate the ability to move information electronically across unaligned organizations. So by any other word, that's exchange. So I think that while we don't still have strong business cases, I think we do have a sense of direction that's fairly critical. Now for us, we've spent a great deal of time the last 6 to 7 months, again, using that claims database to translate opportunity in the early phases of this demonstration to what would this mean to individual businesses, what would this mean to commercial payers, what would this mean to government payers, and actually taking data and using the academic studies of impact on ordering things like that, to translate those into actual projected dollars. We've spent a great deal of time out in the communities of business and insurer. The business community, I think, is intrigued by what we're talking about. The commercial insurer community is equally intrigued but quite doubtful. And I think herein lies one of the issues with exchange, and that is there's a fundamental misalignment of incentive. And the commercial insurers see this and worry about it. That misalignment is that there is actually a great incentive for providers to order another study if the patient happens to be commercially insured, because it's that commercial insured case that has, for at least hospitals, the margin is resting in those commercial patients. Whereas, interestingly enough, there's an incredible disincentive to order another test for a government program patient, because hospitals and providers believe, and I think their numbers support them, that they lose money on those patients. So it's a conundrum. I think the commercial insurers have been very clear with me that they're supportive of what we're doing, but they want us to go out and show that it actually can be have an impact, that the providers will actually change their decision behaviors based on it. And so that's been an interesting point of transition for us in terms of getting to a viable business process that people will pay for.